All right, so this week we are going to go through case study 8 first. Grandma's tummy trouble. She's been wolfing down too many Tums, so her uh, pH balance is imbalanced. So we're going to have to figure out what Granny's issues are and kind of go from there. So something's wrong. Mom's sick. 83-year-old Caucasian female, disoriented, lethargic, vomiting, complaining, upset stomach. So disoriented, lethargic. Those are big notes there. Vomiting, upset stomach, no fever or infection, but appears to be dehydrated. Battery of tests, kidney functions, etc. Of course, we got to look at her brain. Maybe she had a stroke. A lot of times, vomiting comes with a stroke. Um, so I'm concerned about her kidneys. She need to be looking at her brain. Well, she may have some problems with her brain and nerves may be responding to the changes produced by her kidneys. So we do some lab tests here. We've got Grandma's tests. And then we've got normal values to compare Grandma's values to. So that's what the first question is going to ask. Are any of the lab values out of normal range? Do you see some that are too high or too low? So we definitely want to go through. We'll start at serum creatinine. She's at 8.3 milligrams per deciliter. So we come down here. 0.5 to 1.4. Whoa. That's a big problem. What creatinine is a protein metabolic byproduct. That's it. And serum, of course, has to do with your plasma and the nitrogenous waste. This is a specific nitrogenous waste. Another one is urea. So we're going to look at her urea levels as well. But we can see right away that we've got a lot of excess protein, creatinine specifically, way too high, probably like 7 to 8 times higher than it should be. And then her urea levels, their BUN, B-U-N, 7 to 20, she's at a 55. So our two big dogs that we use to check kidney function are both way out of whack. So big indicators of things to come. All right, sodium calcium 15.76. So she's high on the calcium levels too. Let's see, what else do we got going with Granny? Serum sodium and potassium 128 and 2.7. So she's a little low on both sodium and potassium. 128, 2.7. So nothing's looking good, right, so far. Let's see. So serum bicarbonate. So this is her our natural buffer. So this helps with pH. So hers is greater than 40 milliequivalents per liter. Bicarbonate is this one. What was Grandma? Or greater than 40. So she's got a lot of excess buffer going on. So right away, we know we've got a pH issue. So let's see, her serum pH, generally 7.35 to 7.45 is our normal pH. She is basic. She's above the basic range. So, which again, when you have an excess amount of bicarbonate, you're usually going to see a higher, more basic pH. All right, what about her potassium? Is 45. Urinary potassium. We need serum potassium. I don't see the numbers for that. So this is her serum potassium, which we looked at up here. 7.7. So in her urine, she's got 45 milliequivalents per liter of potassium. All right, so 20 milliequivalents per liter in a random urine sample. So grandma was quite a bit higher than that, I think. Yeah, 45. So she's over double the amount of potassium in her urine too. So she's low in her blood. So she has low potassium in her blood, but she has excess amount of potassium in her urine. So she's peeing out what potassium she does have. Okay, so let's see. Number one, that should take care of that. Let's see. Number two, which of the lab values gives you information about kidney functionality? So again, we would be looking at serum creatinine. That tells us that her kidneys are not filtering blood at the glomerulus level. That's the big one, serum creatinine for kidney functionality. Number three, let's see. What does Miss Burrows have alkalosis or acidosis? So again, she's higher than generally 7.0, right, is neutral. Anything above that is basic. But for blood levels, we're okay with 7.2 to 7.3, even up to 7.35 is okay. But she's at 7.67, so she is very basic. So we would say that she has alkalosis. And why are we interested in kidney functions? Well, or of Miss Burrows' kidney function, because kidneys, so you just need to put what the kidney functions are. For number four, they regulate body fluids. They do help with pH balance as well as electrolyte balance. So basically fluid, electrolyte, and pH balance are the main functions of the kidneys. So if her kidneys are dysfunctional, then we're going to have problems with maintaining homeostasis for body fluids, pH, and electrolytes. So, and of course, the list of primary electrolytes is in the case study here. So calcium, chloride ions, magnesium, phosphate, potassium, and sodium. So those are the primary electrolytes. So the kidneys help to balance those electrolytes. Let's see. Number 5 says or asks, what else do you think we need to know about Mrs. Burrows? How could we get this information? So again, we need a general intake from her. So we would get some medical history, maybe some lifestyle choices. Is she a smoker? Is she a user of alcohol? What types of medications is she on, over the counter and prescription? Is she taking them just because she's prescribed them? We need to know if she's taking them, how they're prescribed. We need to know if she's taking over the counter medications. Is she diet, exercise, all that good stuff, right? The usual intake. We need to look at family history if we can. Do we have hypertension or heart disease? We'll also do obviously some sort of vital signs, physical exam with her blood pressure, heart rate, respiration rate, body temperature, maybe even a few mental acuity type of tests as well, mental assessments, just some basics, what's your name, what's your birth date, that type of thing. And then of course, if we have any medical records from her previous visits, that's going to be a big time help. All right, so part one gives us a pretty good indicator that we've got a problem with grandma. So now we need to find out what is she consuming, or is she consuming something that she's not supposed to? And is she consuming too much of something? Is she consuming not enough of something? We need to find out what grandma's putting in her mouth. So, anyhow, Bobby hands the physician uh, the paper bag from the kitchen table from his mom's house. These were on her kitchen table. I don't understand. She's very good about taking her medicine. So in the bag, so basically the doctor said go home and get all of grandma's meds and or your mom's meds and bring them in so we can figure out what she's taking. Because again, a lot of your patients are going to go potentially be going to different specialists. Specialists don't always communicate, with the primary care physician. So, and if this is an emergency room visit, we've got a whole different doctor dealing with grandma. So, you know, so anyway, it's a good idea just to bring in what you can. So he brings in a bag full of pills, and there's hydrochlorothiazide, which is blood pressure, HCTZ, which is a blood pressure medication. So she's taking a blood pressure pill, one capsule in the morning, one at night. Her water pills is what a lot of the older patients call those blood pressure meds, or their water pills. I think at least 1 out of 2 people over the age of 50 is on some sort of uh, uh, water pill slash blood pressure pill. And by the time you get over the age of 80, which is where this patient is, now you're looking at probably 2 out of 3 80-year-olds, if not more, maybe it's even 3 out of 4 at this point, are going to be on some sort of blood pressure med. So anyway, or water pills, diuretics. They made her need to use the bathroom more often. Also in the bag were a bottle of Tums Ultra 1000 milligram and some Alka-Seltzer. Oh, how often are we taking the Alka-Seltzer, or how many Tums? He doesn't know. I'm not sure. I can't be with her all day. She lives by herself. This is the story we hear a lot. So Granny's at home all day, nobody's around, everybody's busy. So she can't be trusted. She's 83. She's by herself all day, and now she's wolfing down Tums and Alka-Seltzers. All right. So we buy them at the grocery store. So I don't see what the big deal is, right? So Bobby, that's son, he doesn't see what the problem is with grandma eating Tums. So traffic, what's wrong with Granny? Looking at her medicines. Do you know anything about the Alka-Seltzer? She's taking the Alka-Seltzer this week because she thinks she's got an ulcer. That's always what she did. I think she was drinking a lot of milk lately. So now she's guzzling tons of milk. So she's getting calcium like crazy at this point. The Tums have calcium, the Alka-Seltzer, and now in milk. So she's craving all of this calcium. It's supposed to be good for your bones, right? Tums, they have calcium. So grandma's been reading Good Housekeeping and Reader's Digest a little too much, and is finding that calcium is good for the bones, which is kind of true, but she's also under the impression that if a little bit of calcium is good for the bones, then a lot of calcium is going to be really good for the bones, especially because she's over the age of 80, and it being a female, she's more at risk for osteoporosis. So she's been, like I say, she's been reading McCall's like crazy and getting hit hard with the osteoporosis prevention ads, as well as drink more milk and eat more calcium, and you'll prevent osteoporosis. So she's buying into that, and now she's in the hospital. So Now that you mention it, Bobby says she did take an Alka-Seltzer every single day I was over there. I think she's finished about 2 gallons of milk just this week. Oy, oy, oy. She doesn't even like milk, but she's guzzling it at a rate of 2 gallons a week. Um, Grew up on a dairy farm. Well, so that part of it too, right? When we're in Wisconsin, we know that dairy and milk is a big deal. It's one of the primary, other than beer, right? It's probably in cheese, maybe, and sausage. Milk is one of the primary um, uh, means of making money for the state of Wisconsin. And um, so anyway, we see this a lot, right, in the clinic with excess calcium consumption. All right. So anyhow, let's check parathyroid hormones. What the heck does that have to do with anything? That came out of left field, right? Well, we should know, right? You guys by now, I would think, have a little bit of an idea that thyroid and parathyroid both have to do with calcium homeostasis. So she might have parathyroid issues, and so she's craving all of this calcium. We don't know. So alarm went off. So okay, we're gonna take a little break here, and he's got to answer this page. So let's answer these questions that have to do with what's going on with Granny now that we're a little bit more in the know with what she's been doing in her spare time. Let's see. So should we be so right away? Should anybody be concerned about Grandma's behavior? Basically, it's particularly with what she's consuming that is not prescription, and of course, right? I mean, many medications that used to be prescription only are now over-the-counter drugs. Usually they're formulated at a lower dose, for instance, Aleve, which is naproxen sodiumate, if you get a prescription for Aleve, you're probably going to get 75 to 200 milligram capsules of Aleve, whereas when you buy Aleve or naproxen over the counter, those capsules are only about 10 to 25 milligrams a piece. So anyway, there's prescription strength, drugs, and then of course your over the counter strength. Okay. So like ibuprofen is another one. A lot of your hay fever and allergy meds like Allegra, Prilosec, one of your acid reflux drugs. Uh, um, Omeprazole, anything in that family is dealing with acid reflux problems and ulcers and things like that. So Prilosec, again, these used to be Nexium, but I think Nexium you still need a prescription for. But anyway, these are a big drug group as well that patients can get over the counter. They think that because they don't need a prescription, that they don't need to discuss with their doctor what they're doing, or that it doesn't really matter. So anyway, sometimes we have to, as medical professionals, we have to inform our patients what is going on, even if they're in their 80s, that they especially need to be informed as to what's going on with over the counter versus prescription, and that we need to be in the know when they decide to start implementing over the counter medications into their routine. So anyway, so because you get the drug interactions with over-the-counter meds and prescription meds, and of course there are other prescription agents and over-the-counter items that maybe aren't even perceived as being pharmacological medications, such as the Tums. Antacids are notorious for being overused by many patients, not just elderly. We've had young people, teenagers, and college age kids who are taking too much too many Tums, and of course, nowadays too, they make them yummy. You get the fruit flavor, the berry flavor, the orange flavor. So they're not as medicinal as they used to be. And they're almost like candy at this point. So, if you've got some antacid, or if you've got some acid reflux issues, it's not usually because you're missing out on Tums or Alka-Seltzer. It's usually other reasons. So anyway, that's kind of why it's important. That is why it's important. That is why it's important to emphasize to our patients that they need to be aware of what's going in their mouth, just because it doesn't have a prescription attached to it. So anyway, foods and beverages, we need to know some of that too, the basics of, especially caffeine. Older people love their coffee, they love their caffeine. Everybody does, it seems like nowadays. So we need to know that. Maybe she's eating a lot of diet or sugar-free type stuff that's got artificial sweeteners and other chemicals that are volatile when combined with certain pharmaceuticals. So we need to know as much as we can about what the patient's putting into their mouth, basically. Let's see. Heck, it's helpful to know, you know, if they're using eye drops regularly. Are they using topical ointments? Are they, buying tubes of cortisone 10 because, and putting it all over their joints because they're kind of inflamed or, itchy or whatever. So, those are corticosteroids. And again, they're over the counter. You can get some of this stuff at a gas station. So, so anyway, we need to know what she's up to, what any of our patients are up to. If they've come to us, things are not usually looking good. So it's helpful to know as much as we can. We're basically detectives, right? So gathering data, gathering info, and just like a detective, some of your patients slash perps are not necessarily going to be forthright all the time either. So it's helpful to, like in this situation, to have family members around that maybe can provide some better clarity as to what's going on than maybe the patient is giving us. All right. So anyhow, we're gonna keep her moving. Could any of Mrs. Burrow's current problems be related to the drugs she's consuming, over the counter or prescription? Right. Well, of course, the Tums she's consuming are high in calcium ion, and her lab values show increase in plasma calcium. Both Tums and Alka-Seltzer are antacids, so they're going to neutralize stomach acid on contact, which again, that's what the McCalls or the Good Housekeeping or the Readers, that's what all the ads are going to tell her, or the Hallmark Channel, advertisement for whatever pill it is. If Tums is on or Alka-Seltzer's there, they're going to say, yep, this is going to neutralize your stomach acids on contact, right? So anyway, basically it's because they're metal salts and these are basic compounds. So these calcium ions are bicarbonate ions. These are going to go after the pH and go after the acidity of the stomach. So, but what that does is it increases your plasma or your serum bicarbonate levels, which is then going to increase the pH into a more basic range, which is again is all what we're seeing based on Mrs. Burrow's lab results. All right. We also in her bag. So there were three things in her bag, right? At least that we talked about. She had the first one was the HCTZ, or her water pills or blood thinners or whatever you want to call them, hydrochlorothiazides. So her HCTZs that she's on, what they do is they decrease sodium reabsorption in the kidney tubules. So remember, um, in the tubular network of the nephron, we get three things going on, right? Well, at the Bowman's capsule, we get filtration. But then the rest of the tubular network, we're going to either reabsorb some of these items from the plasma / serum back into the bloodstream, or we're going to allow the blood to continue to secrete items out of the bloodstream and into the tubules. So what HCTZ does is it decreases sodium reabsorption. So remember, one thing about sodium is that water always follows it. The kind of rules of osmosis is that water is going to try to dilute the area where sodium is. So anyway, if I reabsorb a bunch of sodium, meaning I keep sodium, then I'm also going to keep water. So I might get some swelling or edema, something like that. If I have excess sodium buildup in my body, I will have excess water buildup or edema. So what we do is and that puts stress certainly on the blood flow, on blood pressure. So what physicians oftentimes do when you have a hypertensive patient is they want to thin your blood out. They want to make it so your blood isn't as watery or as, it's less work for your heart to pump. So what they do is give you a pill, these water pills that block the reabsorption of sodium back into the bloodstream. So if I block reabsorption of sodium, where does sodium go? Well, it stays in the tubular network and ultimately becomes part of your urine, and then you pee it out. And remember, wherever sodium goes is where water is going to follow. So if I'm hanging on to sodium in the body, then I'm going to hang on to water in the body. If I'm eliminating sodium through the tubular network and out through the urinary system, then I'm also eliminating water. So that's why they call these water pills. They make you pee a lot because you're getting rid of sodium. So knowing that she's taking HCTZ is going to also give us some indications as to what's going on potentially at the big picture level with this particular patient. So if I decrease water, where does the water come from? So if I get rid of sodium in my urine, water is going to chase it, right? Well, where's the water come from? Well, it comes from the cells, it comes from the blood, it comes from the plasma, especially. So if I start dumping sodium, I'm going to dump water, I'm going to see a decrease in plasma volume and therefore a decrease in blood pressure. Yeah, I don't have to pump as hard if there isn't as much to pump. So anyway, blood pressure is going to remain decreased despite an increase. So anyway, let me see. I've checked my notes. Seems like there was something else I want to mention. So anyway, the thiazide, they're called diuretics, right? So that group of diuretics is what that was what I want to mention. So anyway, their HCTZ is a thiazide diuretic, meaning sodium is blocked from being reabsorbed in the tubules. So we eliminate it in the urine or secrete it in the urine, which means water goes with it. Let's see. Number 3, what's PTH or parathyroid hormone? Where does it come from? What is its function? So we've gone through this in the past. I think in general, we talked briefly about the parathyroid gland, the 4 little mini M&Ms that kind of hide the posterior aspect of the thyroid gland. And parathyroid hormone is the primary and I believe the only hormone that's produced and released by the parathyroid glands. Again, there are four of them. There are four of them. Two pairs on the posterior, the back side of the thyroid, which again is kind of um, you know wraps around the trachea there, the larynx area, the larynx and trachea is right where you'd find the thyroid gland, and again the parathyroid's behind them. Release of parathyroid hormones is going to be stimulated when we have low calcium levels in the plasma. So when your blood calcium levels are low, parathyroid hormone is going to get released. So how are we going to get calcium increased to normal in the bloodstream? Well, parathyroid hormone we're going to get it from bone, right? Where does calcium live in the body? Of course, calcium is stored in the bone. So if blood calcium levels are too low, parathyroid hormone is going to get released, and the target cells for parathyroid hormone are going to be osteoclasts. So if you recall from the bone chapter, last semester, we talked about bone cells. Osteoblasts tend to build bone. Osteoclasts tend to break down bone or chisel bone. So blasts build, clasts chisel. So if I'm low in calcium in the bloodstream, all I need to do is chisel away a little bit of bone, and calcium ions will get released into the bloodstream, thus causing the low blood calcium levels to increase and get closer to normal. At that point, then we would stop releasing parathyroid hormone. So again, parathyroid hormone is released when we have low calcium in the blood. And remember, all hormones have a target. So the target for parathyroid hormone are going to be osteoclasts. Okay, so they're going to break down bone tissue, and that's going to again cause an increase in plasma levels and plasma concentration of calcium. So it's we see the opposite with what's called calcitonin, and calcitonin is a thyroid hormone that's going to tone calcium. In other words, when I have high levels of calcium in the blood, so the opposite of the previous scenario. So if I have an excess amount of calcium in the blood, I need to tone the calcium down a little bit. So calcitonin gets released from the thyroid, and then it's going to trigger the storage, the delivery and storage of calcium out of the bloodstream. It could be stored in bone, of course. We could also store or deliver calcium to muscle. Remember, primary muscle physiology involves a lot of calcium to be released. So anyway, parathyroid hormone. When I have low calcium levels in the blood, I'm going to release parathyroid hormone so I can increase calcium levels. So Ford segues us right into, why do you think the physician's interested in knowing PTH levels? Well, we saw that Mrs. Burroughs' plasma calcium is too high, so we might expect that abnormality would be increased levels of PTH. So if PTH is normal, there may be other causes of that increased plasma calcium. So basically what it's saying is, so if she has a parathyroid tumor, we'll say, so she gets excess parathyroid. Remember, when your blood calcium levels are low, you're going to release parathyroid hormone to bring blood calcium levels back up to normal, and then it's supposed to shut off. But let's say it doesn't shut off. Let's say parathyroid, I've got a tumor, or I've got some sort of mutation going on with the cells that produce parathyroid hormone. And so they get told to stop releasing it once the levels are normal, but they choose not to. Well, they don't choose not to, they just don't. They continue to release parathyroid hormone. So what would happen? You just continue to get calcium broken down in the bone and released into the blood. So then we'd see an elevated we'd see an excessively elevated level of calcium in the blood if I have an excessive amount of parathyroid hormone. So remember, parathyroid hormone causes an increase in blood calcium levels. And if that increase goes past the baseline and now into the excess level, at that point, I may have a parathyroid problem. So that's why we're checking it. So Mrs. Burrows' plasma calcium's too high. Maybe it's because her parathyroid is producing way too much parathormone or parathyroid hormone or PTH, whatever you want to call it. She's releasing way too much of that. So she's getting way too much bone broken down. So therefore she's getting an extreme or excessive amount of, we call it hypercalcemia. So if PTH levels are normal though, then her increased plasma calcium concentration is probably the result of something else. Maybe she's consuming too many Tums, or maybe she's consuming too much Alka-Seltzer, or too many calcium supplements, drinking too much milk, whatever it might be. So that's what we're looking at. Let's see. Hopefully that makes sense. So again, if her PTH levels are normal, then the reason for all this excess calcium is going to be potentially that she's consuming too much calcium. Now, the other thing we could look at, and I don't do it, we don't do it in this case study, but another thing that the physician could do is look at her calcitonin levels, right, from the thyroid. So if I have elevated calcium levels in the blood and I check PTH and that level is normal, I might as well check calcitonin levels. Because remember, under normal conditions, if I have excess amount of calcium in the blood, I'm going to release calcitonin to bring the level of calcium back down to normal. So if it stays elevated, maybe I have no calcitonin. Maybe the thyroid is not producing calcitonin, so it never gets released to bring calcium levels out of the bloodstream down to normal. So we can look at that too, certainly. But anyway, what are normal levels for parathyroid hormone? They vary in range, pretty big range, 11 to 10 to 50. I've seen 15 to 60, 11 to 54. I mean, so anyway, it's pretty broad range, but these are very small increments per milliliter of PTH. So anyway, 11 to 54 PGs per ml. There you go, 10 to 55 picograms per milliliter. So PG per ml is your standard. Okay, 10 to 55. Okay, so those are normal levels for PT. I don't know if we have the numbers for grams. Oh, we get that later. Okay. Here it is, part 3, Bobby and Charlotte hospital. So this is son and granddaughter, I believe. How's everybody doing? Better, thanks. So Mrs. Burrows feeling better, less confused, sitting up in bed. She's chatting and kind of napping occasionally. But she says the doctor comes in, she's doing better. Stomach doesn't hurt. Shouldn't I take my Tums? I don't want to fall down and break a hip. I think it's about time for a big old glass of milk while I'm at it. Doctor's kind of, he's thinking, oh, brother. But he's, they keep together. Oh, I don't think there's a danger of falling here. In fact, you're in a safe place. I don't think you should be taking Alka-Seltzer or Tums, since that's what caused the problem. That's why you're in here. So we are going to discuss that. Okay, it looks like your serum PTH is 8 milligrams per deciliter, which is what I expected. This tells me the antacids have altered your kidney function, and that's how you've ended up here. So, see, we've got a difference in so milligrams per deciliter. So we would have to convert that, so which we will just in a second. So anyway, because remember, we're dealing with micrograms per milliliter, and she's got milligrams per deciliter. So let's see if that adds up. All right. So anyway, how is she? She's sick now because of the Tums. Well, how can they be selling that stuff if it makes people sick? Well, I think she's sick now because she's taken too many. So it's not because taking a Tums is going to do it, but Grandma's been overindulging in the Tums and Alka-Seltzers. But we thought the kidney would just eliminate that, though. Yeah, good thinking. They might for a little while, but the kidneys are very they get tired out, especially when you're 83. So we don't want to stress them out. I mean, why in the heck would you give your body something in excess in any form? That's gonna say, well, the kidneys will just take care of it. Yeah, well, they're old and tired, and they don't want to have to take care of your extras. So Granny needs to lay off the Tums and stay in her lane here. So that's basically the doctor's telling her. You're on the right track. Kidney is responsible for regulating the amount of every substance in your body, not just calcium. Granny's got two big problems: too much calcium and too little acid. Oh, so who knew we could have a problem with too little acid? Well, that's what we have here. This is alkalosis. Very diagrammed kidney excretes acid. So figure one diagram of the secretion of hydrogen ion in the tubular fluid from cells of the PCT. A slightly different mechanism works further along the nephron in the distal convoluted tubule, where we see reabsorption and secretion of bicarbonate ion into the renal tubule. So basically what this is saying is that hydrogen ion, this is pH, this is the H of pH, right? So if I have excess hydrogen ions, that means I'm acidic. So we have this kind of inverse kind of base 10 formula for figuring out pH. But remember, the higher the amount of hydrogen ions, the lower the number is on the pH scale. So a pH of 1 or 2 or 3 is acidic, but that also means it has the highest number of hydrogen ions. So it could be counterintuitive a little bit, but that generally is the path you want to take when you're thinking about pH and acidity. So so if I eliminate hydrogen ions in my urine, it's going to keep my blood more neutralized, hopefully. So one way, again, that's if I have an acidic situation. Now with our patient, we have the other way around. She doesn't have too much pH. She doesn't have enough hydrogen ion concentration. So so this is showing hydrogen ion being secreted. This is the tubular fluid. And this is the interstitial fluid. So this is the fluid that's basically between the capillary of the bloodstream and the tube. So this is kind of the in between, the interspace, right? Interstitial. So this is between the inside of the bloodstream and then the inside of the tubular network. So anyhow, we're seeing bicarbonate ion staying in the interstitial fluid. Again, this is a primary buffer. We also see this excess hydrogen, which is your pH, right? This is the acid, what makes your blood more acidic. We see it leaving the blood and going into the proximal convoluted tubule. So again, this is just showing one way how we can pull hydrogen ion and put it into the tubular network, so we can eliminate high excess hydrogen ions, thus bringing pH into a more neutral territory. So anyway, this is how things normally would work. So we have this constant sodium going out, potassium going in. So we have this sodium, this green is a sodium potassium pump. So we see three sodiums going one direction, two potassiums going the other direction. All right, so let's look at a couple of questions here. What enzyme is going to catalyze the formation of H2CO3, so bicarbonate from carbon dioxide and water? So carbon dioxide, so catalyze, so a catabolic reaction just means we're going to break it down. So we're going to take two chunks and break them into, or take a chunk and break it into smaller chunks. So what it's saying is what enzyme is converting the formation of H2CO3 from carbon dioxide and water. So where does carbon dioxide and water come from? First off, well, certainly we drink water, but CO2 is a waste product of cellular respiration, but so is water. So whenever our cells go through cellular respiration, the waste or the byproducts are CO2 and H2O. So carbon dioxide and water, we can add an enzyme and put these two together and get bicarbonate ion. So it wants to know what enzyme is going to be necessary to get the formation of water and carbon dioxide. So this is a reversible reaction, so we can go either way with it. And the enzyme has got to end in an ASE. So the enzyme is called carbonic anhydrase. So ASE, so anhydrase. So hydro, right? We're seeing the word for water, and an meaning not. So so we're an enzyme that's breaking up water in essence, and that involves some sort of carbon action as well. So carbonic anhydrase is going to be the primary enzyme for the formation of bicarbonate ion from carbon dioxide and water, which again are the waste products of cellular respiration. So that's going on all the time. So glucose and oxygen to the cells give us the ability for ATP, and the byproducts are carbon dioxide and water. So anyway, diagram outlines the mechanism by which hydrogen ion is actively secreted into the PCT of the kidney nephron. What other substances must be transported from the tubular fluid into the proximal convoluted tubule cell, or from the PCT cell into the interstitial fluid across the basolateral membrane as part of the transport of hydrogen ion? So that's a lot of words and a lot of action. So basically, if we go back and we look at our diagram, we can see we can answer these just based on the direction of all these arrows. So we do see sodium ion, and sodium ion generally, of course, is going to be co-transported. So that's what we see here. Sodium ion being co-transported. Okay. The hydrogen ion secretion mechanism here is an antiport that requires sodium transport in the opposite direction, so down its concentration gradient. So sodium moves from high concentration to low concentration, just like all items. And if that means it's moving down its concentration. So if I have high levels of sodium in the proximal convoluted tubule, sodium will naturally diffuse across the cell membrane, and it's going to be helped out by this co-transporter. This is an integral membrane protein, so it's going to be some sort of protein carrier or channel that's inside embedded in the cell membrane. Okay, so we got the cell membrane. I've got an integral membrane protein carrier. It's a co-transporter. So when sodium comes in, hydrogen ion is going to be coming out. So that's what we see in this pattern. Now, sodium and potassium, as we see at the bottom right, remember that's going to have to deal with some sort of a pump. So we call that the sodium potassium pump. Okay. So sodium and potassium are transported as well via that sodium potassium pump. And again, that's a 3-to-2 ratio. And let's see, what else does it say? What other substances? HCO3, so bicarbonate ion, HCO3 minus. There it is right here. That's also getting transported. So that looks like it's being co-transported as well, this time with the chloride ion. So we move the HCO3 concurrently with the hydrogen ion transport out of the cell. So for every hydrogen ion secreted into the tubular fluid, one one bicarbonate ion is going to get reabsorbed into the interstitial fluid and ultimately into the blood. So we're going to eliminate hydrogen ion. Okay, so we're eliminating hydrogen ion. That's going to help with decreasing pH, or I guess technically increasing, bringing pH closer to neutral is what we're going to be able to do by getting rid of some of this hydrogen ion. So PCT means you're going to pee it out. Okay, so the opposite of hydrogen ion is bicarbonate ion. So you can see we've got a plus and a minus. So this is the opposite ion. This is the buffer. So we want to hang on to buffer. So we're going to reabsorb. So secretion goes into the proximal convoluted tubule. Reabsorption goes back into the bloodstream. So we're going to reabsorb bicarbonate as we get rid of concurrently as we get rid of hydrogen ion. So those are the main that's the main thing that's going on there. Let's see, what would happen to the amount of hydrogen ion secreted into the renal tubule if the activity of sodium and potassium ATPase were increased? Are there diseases or other conditions? I'm sure there probably are. So we'll look at those. Let's see. So what happens when the amount of hydrogen ion secreted in the renal tubule if the activity of sodium potassium ATPase were increased? So what we'd see is the increased activity of the sodium potassium pump. Remember that sodium potassium ATPase, this is the pump. So aldosterone we've looked at before. That's another adrenal hormone that is going to help with sodium reabsorption. So aldosterone activity is going to increase the activity of the sodium potassium pump. Again, we want to get sodium reabsorbed into the bloodstream, maybe because we want to retain water. Remember, water follows sodium. So if I am dehydrated, I am going to increase my aldosterone activity so I can increase sodium reabsorption into the bloodstreams and thus water reabsorption. Let's see. So aldosterone activity increases the activity of the sodium potassium pump, and aldosterone activity may be increased as well if the GFR, glomerular filtration rate, is decreased. So if the amount of stuff, the blood and electrolyte plasma or serum electrolytes, if that amount is decreased, such as in kidney failure, then that would also trigger aldosterone release. So let's see, diuretics inhibit the reabsorption of sodium. So that might also promote aldosterone activity. Because again, if I'm preventing sodium from being reabsorbed, the brain and the body are saying, hey, we want to reabsorb sodium, so aldosterone is going to keep getting released. Um, so a lot of stuff actually going on here. So again, these diuretics inhibit reabsorption of sodium. So therefore, we're going to see an increased activity of aldosterone because the body's saying we don't have enough fluids. We keep peeing out everything. And the brain's telling the adrenal glands, well, then secrete more aldosterone because that's going to allow us to reabsorb sodium and bring water with it and hydrate our internal organs. So again, these diuretics, man, they can do a number on the body. Okay, so anyway. Okay, calcium. What about the calcium? Here's the chemical reaction. Again, we've got the waste products, carbon dioxide and water from cellular respiration. We've got a reversible reaction. Those form bicarbonate. I can break bicarbonate into hydrogen ion and the bicarbonate ion. So hydrogen ion, bicarbonate ion, and it becomes sodium bicarbonate as well. So carbonic, this is called carbonic acid. Again, if we put a H in front of things, oftentimes, if it's not charged, it's going to be some sort of acid like hydrochloric acid, sulfuric acid, carbonic acid. All right. So it works as a buffer. We're learning about this in biochemistry. It can tie up hydrogen ions when there are too many, or it can produce more hydrogen ions when there aren't enough. So again, if I don't have enough hydrogen ions, I'm too basic, which is what we have with our patient. We can reabsorb some of these hydrogen ions that we get from carbonic acid, which again, this is the byproduct of cellular respiration. This is why it's so important to breathe. That's why it's so important to have functional kidneys and functional respiratory system, because too much cellular respiration and not enough external respiration leads to a buildup of carbonic acid, and that leads to a buildup in acidity in the body. So we want to keep acidity or pH as neutral as we can. All right, kidneys regulate the concentration of bicarbonate ion by preventing its loss in the kidney tubules. It can secrete it back into. So again, it's this back and forth thing that we can do. All right, pH is too high. Would it develop this if she's not taking all those antacids? I mean, there's a problem with her breathing now. So now again, we talk about breathing is your primary source of regulating pH. So if you're ever asked in a test, what's the primary body system that regulates pH, you're definitely thinking the respiratory system, because the respiratory system is going to eliminate the buildup of carbon dioxide that we see right here. So this carbonic acid in the lungs will get converted into carbon dioxide, which is what we are exhaling. And if we don't breathe properly, we're going to get this buildup of carbonic acid. Regulation of calcium involves kidney functions. Draw another diagram of kidneys reabsorbed. So we get another diagram, this time of calcium reabsorption. All right, let's get to the bottom of this. So we finally made it. All right, so no, there's not a problem with her breathing. All the respiratory system can't. So what'll happen is if she's not eliminating, which she did have breathing difficulties at the beginning. If you're unable to eliminate hydrogen ions through the urine, you're gonna hyperventilate. So the respiratory system will compensate for the urinary system's inability to eliminate hydrogen ions by breathing more. So we'll see some breathing difficulties, potential hyperventilating. All right, so let's get to it. what are we doing? Is there a problem with her breathing? Doctor says there's no problem. Uh, again, the respiratory system will compensate from metabolic alkalosis. So that's what she has. She has metabolic alkalosis. So basically, again, we're saying her pH internal, her serum pH is in the basic range. So they call that alkalosis. And again, if it's um, due to if it's a kidney issue and blood serum issue with pH, we call that metabolic alkalosis. The other way around is um, if she's retaining too much hydrogen ion, then she would end up with metabolic acidosis. So she'd be too acidic. If her pH of her blood was like a 5 or a 6 instead of a 7.4, then we would say she has metabolic acidosis. That's not what she has. She's alkalosis. Okay, so again, respiratory system will compensate if I have metabolic alkalosis. So for our patient, she doesn't have enough hydrogen ions, right? So alkalosis means I'm missing some hydrogen ions. So she's been peeing all of them out. Okay, hydrogen ions have been getting peed out. So it's brought her pH into an alkalosis range. So what her respiratory system is going to do is hypoventilate. She's not going to breathe as much. She's going to be labored breathing. If she decreases her respirations, then she holds on to more carbonic acid, thus holds on to more hydrogen ion, thus brings her alkalosis maybe into a more neutral state. So basically what she's doing by not breathing properly is allowing CO2 to build up in her blood, thus forming carbonic acid, which then dissociates into hydrogen ions. So the excess hydrogen ions will hopefully bring that alkalosis back into neutral. If it will. Let's see. I think I changed up the question from that last. Here we go. Describe how, so you haven't drawn anything. So describe how the respiratory system responds to alkalosis. Again, we kind of just went through it, but you're going to see the respiratory system kind of slow down, right? So an alkalosis. So that means we don't have enough hydrogen ion. So I need more hydrogen ion. So I decrease my breathing, allowing for more carbonic acid to build up, thus dissociating it into hydrogen ions, thus adding the hydrogen ions. So that's what the respiratory system is going to do. Let's see. Why do you think the physicians suspected that PTH levels were too low? Well, again, PTH and calcium kind of go hand in hand, right? So low plasma calcium stimulates the release of PTH. PTH then is supposed to cause more calcium to go into the blood, right, from the bones. And at some point, we shut that off once we hit normal levels of blood calcium. In our patient situation, we see PTH levels, or we see blood calcium levels are elevated. And so maybe her PTH is continually getting released. So it's continually triggering calcium to be broken down and put into the bloodstream. And so we just have this constant flow of calcium into the blood. So Mrs. Burrows, high levels of calcium levels. So if this if the high levels of calcium are due to high levels of parathyroid hormone, we would say she has hyperparathyroidism. But she has lower than normal PTH levels, indicating that her plasma uh, calcium levels are appropriately inhibiting PTH release. So that, right? So um, she has high calcium levels that should stop PTH production. So, but the doctor wanted to make sure. Um, so the elevated calcium is not the result of overactive parathyroid. So that's probably a good thing. I think he's concluding it's just a consumption issue. Her intake of milk and calcium is contributing to all that elevated calcium levels. We could have a tumor or some type of cancer going on in the bone that's causing excess calcium to be released into the bloodstream. It's hard to say, but knowing what we know about what she's been consuming, it's probably safe to say that if we back her off on the Tums and the Alka-Seltzer and the milk, she's probably going to level out. Diuretics produce or contribute to alkalosis and hypercalcemia. So remember, HCTZ is inhibiting the sodium chloride transporter. So more sodium, it gets left in the tubular fluid, and thus promoting loss of water. So again, if more calcium or sodium, goes into the tubular network, water follows it. So we lose water. If we lose sodium, we lose water. If we gain sodium, we gain. And what the HCTZ does is it stops the ability to retain sodium. It promotes getting rid of sodium. Let's see. So decreased sodium entry into the cell from the tubular fluid means that intracellular sodium concentration goes down. So this means that we're losing sodium. So sodium inside of your cells is going to decrease. So that's going to enhance the driving force for sodium to enter via the sodium calcium transporter that we saw earlier. So that's going to result in more movement of calcium back into the body, so or calcium reabsorption. So if we go back up, let's go over here. So you recall, where was it? Sodium, calcium, sodium, calcium. There we go. So calcium and sodium go opposite directions. So again, with this co-transporter. So if more sodium is leaving the body, then more calcium is staying in the body. And so that's in part why we are seeing her blood calcium levels so high. So because she's on this diuretic, on top of consuming all of this calcium, she's also on a diuretic that's eliminating sodium and water. So as we eliminate sodium, we retain calcium. So not only is she retaining calcium because of the diuretic, she's also consuming a bunch of calcium. So, anyway, let's see. So that's the HCTZ story. What else? Was there anything else? I think it's probably good. I think the moral of the story is that, you know, you have to talk to your physician if you're putting anything into your mouth and you're already on medications. Um, and we see that her doctor prescribed her water pills, which we know allow for sodium to be released from the body, thus causing water to be released from the body. But at that same exact time, we're releasing more sodium because, again, the HCTZ medication that she was given blocked sodium from being reabsorbed into the body. So it kicks sodium out of the body, kicks water out of the body. And again, at the same time, it's causing a retention of calcium. So her calcium levels increase in her blood. and she was never able to get those calcium levels down because she kept consuming more and more calcium because she was told that eating Tums and drinking a bunch of milk will build strong bones and prevent osteoporosis. So what it ultimately has done is caused all kinds of pH imbalances for her. So we're probably going to have to discuss her blood pressure medications or her HCTZ consumption, as well as her calcium consumption. All right, so that is that case study. Now, I want to look at case study 9. I think we'll have some time. Oh yeah, the deer collision. So this one goes into pneumothorax a little bit. So we'll get into respiratory. Okay, pump that up. All right, so we've got a cross-country runner, and unfortunately, she gets into a little bit of an accident. I don't think she uh, necessarily knew it was coming or was certainly responsible for it, but we do see that, we do have a few issues with our cross-country runner. So let's get right to it. All right, so it just starts off talking about what's going on and really shoving through, search of signs, quickly push back, free line, impact with one of the deer, red hair, blue uniform here. So we've got labored breathing, wet gasping sound, punctuated with grunts of pain. So yeah, want to make sure her neck is okay. So we're gonna put a cervical collar on and hope that that is good. And pale face, struggling to breathe, smear of blood on the side of the uniform. Okay, so we've got some problems. Days slumped to one side. EMTs are there. All right. So, what are some potential injuries that Hannah could have sustained? Well, she got hit by a deer. She got labored breathing. So, maybe broken ribs, um, which could lead to other broken bones. Could be a clavicle, sternum, dislocated shoulder. Um, All right, so that's one thing. We hear some gurgling and weird noises when she's breathing. She's having trouble breathing, so we have some sort of punctured lung. If we see fractured ribs, we could assume there is a possibility of punctured lungs to go with it. She's probably got some cuts and scrapes, so lacerations. She might have a concussion. She's been dazed. She hit her head hard, so she's got quite a few things that could be that we'd want to look at. Eh, Brent, trauma case arriving in 10 minutes. Bay 2 needs to be ready. Double check the supplies. Hannah Ellis, 19-year-old female, hit by a deer while running. BP's 100/80. Ouch. Pulse 108, respirations 23 per minute. So that's a little high, right? 12 to 18 is about normal. Pulse is a little high. We like 60 to 100 at the most. Blood pressure, we've got diastolic, looks great, but systolic, not so good. So there's a breach somewhere. So there's a pressure. The pressure against the walls of the arteries when my heart contracts is not creating a lot of pressure. So there's a breach somewhere. We've got shallow breathing, sucking chest wounds, There was a chest seal applied in the field, no signs of tension pneumothorax. Minor lacerations, contusions, no obvious fractures. Pupils are equal and reactive. Awesome. Hit by what? Yeah. Oh man. Heart rate's a little high. Respiratory rate's a little high. Reactive pupils. So this is good. Pupils are equal and reactive. That lowers the chances she has a head injury. Good. So no head injuries. We get to focus on the chest wound. Take some deep breaths, Hannah. No breath sounds on the injured side. No evidence of a cervical spine injury. That looks good. A possible hairline fracture of the fourth rib. And that's one heck of a pneumothorax. So turn to one side, yelp of pain. It hurts. You can see why. Ugly bruise was forming on the lateral chest wall just below the inferior tip of her scapula. Ragged 2-inch laceration extending deeply into her skin. Peeling away the adhesive placed by the EMTs, getting a better look, gurgling and sucking each time she inhales, and a small amount of blood foaming at the edges of the wound. Yep, all the way through the chest wall. Sorry, I know this isn't comfortable. I don't feel any obvious puncture in the lung, but I can't be sure. How did that happen? Penetrating wound, no lung injury from a deer. My guess is she got clipped by the tip of an antler, maybe the edge of a hoof. It must have hit just right not to cause more serious fractures or penetrate deeply enough to hit the lung. You may not feel like it, but you're pretty lucky. Okay, good. So she does not have a punctured lung. That's great. She does have a pneumothorax, which is kind of like a punctured lung. So let's talk about that for a second. So pneumothorax happens when the air enters into the pleural cavity. So you'll recall when we have the lungs, you've got you've got two layers of tissue surrounding the lungs, and in between those layers is a cavity called the pleural cavity. So when air enters the pleural cavity, so it's between the visceral, which is the layer right up against the lung, and then the parietal, which is right up against the rib cage. So on the underside of the rib cage, the thoracic cage, is a layer of tissue called the parietal pleura. And then just deep to that is going to be the parietal or the pleural space or pleural cavity. And even deeper to that, when we get to the lung, we have a covering called the visceral pleura. In a spontaneous pneumothorax, air may leak from the lung itself, such as lung diseases like emphysema. You might get a rupture internally in the lung. And a traumatic pneumothorax, a penetrating injury to the thoracic wall, allows atmospheric air to enter the pleural cavity. So that's what we have here. We have a traumatic pneumothorax. So we have a penetration injury to the thoracic wall, and what we get is atmospheric air going into that cavity. So air moves from high pressure to low pressure. So if it's 760 millimeters of mercury out here, and it's 750 millimeters of mercury in there, air is going to toward that lower pressure. So we've got a chest x-ray, dense objects like bone appear white. Is the pneumothorax on the left side or right side? Um, so we've got a normal chest. So panel A is a normal chest x-ray. Hannah's x-ray looks similar to panel B. So this is what we see as a normal x-ray. Let's just look at some of the features. So you see all of the white is bone or harder, more solid structures. So this might be the heart right here. Okay, this is the diaphragm. What we see are a lot of the bronchi, and then these are bronchioles, some of these smaller tubes. You can see there's like mottling, M-O-T-T-L, mottling, kind of pockiness in here. So that tells us that I've got soft tissue with a lot of little micro tubes kind of going into the soft tissue. Now, when I look over here on the right side, or this would be on the left, her left lung. So, so as we're looking at it, okay, so this would be her left side. And again, we know it's the left too, because the heart, remember, it does take up more room on the left. Now, if I look at this left lung, it does look very similar to what I see over here. I see a lot of white kind of chicken scratch, like lines in through here. I see the same thing going on over here. But when I come over here, I don't see much of anything here. It looks pretty clear. Mm. So this right here might actually be her lung. This is her heart right here, just like we see here. And then this is her lung here. But notice I don't, it's like there's nothing here. See how it's kind of cloudy over here? That tells me that's a lot of soft tissue. Here it's just empty space. Hmm. So she's got a pneumothorax on her right side. There's no mottling. Again, mottling. That's just kind of the relief that you see, the lines and where the bronchioles and some of the blood vessels and some of the tissue, lung tissue would be. But again, that right side of the thorax and on B, that's really black there. There's nothing. The edge of the collapsed lung is the sharp line, the kind of a dark space around it. So whereas you have the left lung looks pretty good. Hmm. So like I say, this might be kind of the edge of the lung right there. All right. So will her pneumothorax spread and affect the other lung? Sounds good. Thank you, Sarah. Okay. Will her pneumothorax spread to affect the other lung? And again, generally, no. There's uh, the pleural cavity of one lung doesn't affect the pleural cavity of the other lung. They're separate from one another. So then it says describe two factors that normally keep the lung inflated against the thoracic wall. So normally the lung is going to remain inflated because of the presence of pressure, of course. There are elastic fibers within the lung that promote this kind of recoil and deflation of the lung. Again, unless these external forces don't allow it to do so. Normally the lungs going to remain inflated against the thoracic wall because of two factors. And the pressure of the pleural cavity is about 4 millimeters of mercury less than the pressure in the alveoli of the lung itself. So what we would call intrapleural pressure. So the pressure between the two layers, so the pleural cavity. So there's pressure in the pleural cavity, and it's about 4 millimeters of mercury less than the pressure in the alveoli, what we call intrapulmonary pressure. So we have a pressure gradient. We have higher pressure in the alveoli than we do in the pleural cavity. So that higher pressure inside the lung is going to keep it inflated okay, and expanded against the thoracic wall. And there's also in that pleural cavity a pleural fluid. It's called pleural fluid. And that helps to keep that visceral pleura stuck to the parietal pleura. And it sticks because of something called surface tension. So, so you've got this parietal layer and this visceral, so the lung is here and the lungs here, the visceral layer covers the lung. And then the parietal layer is right outside of that. So you have this cavity right in between. And there's a fluid in between that cavity, and it kind of keeps these two, and the fluid, if you put fluid in between two objects, it creates surface tension. It actually kind of keeps them adhered together. So the presence of that pleural fluid in between those layers is going to keep them so they're connected. Now, if I breach that layer, I poke a hole in that layer, then all bets are off. So that's what we have with a pneumothorax. So, which is the next question. So let's, or part B, I guess, of number 4. How did the pneumothorax cause her lung to collapse? Because that pressure gradient that we just mentioned has been disrupted. So intrapleural pressure is no longer less than inside the lungs, or intrapulmonary pressure. So in Hannah's case, the air entered the pleural cavity through the chest wound until the intrapleural pressure was equal to the atmospheric pressure. So and then once the intrapleural pressure exceeds the intrapulmonary pressure, that's going to cause. Plus, we've got this the elastic recoil properties cause it to recoil and pull away from the thoracic wall and collapse. So basically what we did is we poked a hole. So we poked a hole right here, and then that caused the lung, that caused the air from out here to come in. So now the air pressure here is greater than inside the lung. So it's just pushing and pushing and pushing against the lung. And then that caused that lung then to deflate. All right, and then 5 asks, let me scroll down. When the adhesive seal was removed, we heard a sucking sound. So what's that because of? That's air being drawn into the pleural cavity past the edges of the wound. So air from outside going past the edges of the wound when she inhales, the intrapleural pressure. So the pressure in between in the pleural cavity has to be lower than atmospheric pressure. And as she expands her rib cage, intrapleural pressure or intrapleural volume increased, which resulted in a reduced intrapleural pressure. So pressure and volume are inverse. So as her intrapleural volume increased, so once we punched a hole in her thoracic wall, what happened is air from the outside, from the atmosphere, went into that space between her rib cage and her lung. So we poked a hole. We didn't go all the way and poke the lung. We just poked a hole and allowed air to get into the space that surrounds the lung. And so what that did is caused the volume of air in that intrapleural space just went way up, right? We just increased the volume in that intrapleural space. So if we increase volume, we decrease the pressure. So now that reduced intrapleural pressure is going to cause that lung to just shrivel up and collapse. Josh can't breathe. Yeah, we know. We're trying to help with that. We're going to need to confirm there isn't any injury of the lung. We need to clean the wound. Yuck, right? Then we can close it up and get her going. But we don't want this to turn into a tension pneumothorax before she gets to surgery, because her blood pressure is starting to drop. Air repeatedly enters the pleural cavity with each breath, but cannot escape. Okay, so that's a tension pneumothorax. The volume and pressure in the pleural cavity increase significantly, pushing that mediastinum over to the opposite side. That can push up against the heart, lead to a drop in blood pressure. So So anyway, he's gonna have to insert a tube into her chest to help her breathe better. So he's gonna swab it to clean it up a little bit, a little local anesthetic, uh, quick cut with a scalpel, put the tube in and carefully stitched into place so no air could leak out around it. So he applies a bandage over it. So again, we have to keep it covered so no air gets in from the atmosphere back into that area. Okay, Hannah headed up to surgery. Outlook is good and excellent. All right, so why won't it reinflate on its own? So let's take a look at that. Oh, Hannah's lung not reinflate on its own. Well, remember, lung isn't in contact with the thoracic wall anymore. So even as that wall moves, it's not pulling the lung with it. So we can't increase volume of the lung, thus decrease pressure, thus allow air from the outside to go into the lung. So if the lung volume doesn't change, intrapulmonary pressure doesn't decrease below atmospheric pressure. So without that pressure gradient change, air can't go into the lung. So again, air is going to go from high concentration or high pressure, we'll say, to low pressure. So the lungs being attached by these pleura to the rib cage as well as to the diaphragm. As soon as I expand flatten out the diaphragm and expand the rib cage a little bit, what I'm doing is increasing the volume of the lungs. So as I flatten out the diaphragm, so I have a lung here. As I where'd I go? As I flatten out the diaphragm, it's causing the lung to get bigger. That increase in volume actually causes a decrease in pressure. And the pressure in the lungs, as it goes down and gets below the pressure of the atmosphere, that's what's going to then lead to air moving from high pressure to low pressure. Okay, so if I can't pull the lungs down and increase the volume of the lungs to decrease the pressure, then I'm not going to get any air going into the lungs. So how will inserting a chest tube, I think that's what that asked, right? Yeah, it won't reinflate on its own because it's not adhered anymore to the lung, and I can't get it flattened out to increase its volume to get that decrease in pressure to happen. All right, so if I put the chest tube into the pleural cavity, how's that helping to reinflate the lung? Well, so I put the chest tube in, into the side where the wound is, and that is going to allow basically me to vacuum or to pull the air out of that pleural cavity. So if I'm decreasing the volume of air in the pleural cavity, okay, so that's the idea. So that chest tube is allowing me to remove air from the pleural cavity, hopefully reducing that intrapleural pressure. And as that intrapleural pressure drops back below where it's supposed to be, remember it's 4 millimeters of mercury lower than the pulmonary pressure. So pressure in the lungs is 4 millimeters of mercury higher than the pressure around the lungs. But remember, with a pneumothorax, I now have atmospheric air pushing against the lung and increasing now the pressure in the intra pulmonary region, or that intrapleural region. Okay, so the intrapleural pressure is always lower than the pressure inside the lungs, unless I get a pneumothorax. Now the pressure is going to be greater. So what the chest tube is going to do is pull all that air that's in the intrapleural space. It's going to pull all that air out of there. So then the lung will eventually expand and fill that space back up once the pressure gets 4 millimeters of mercury below that pulmonary pressure. So, and that wound would have to be super sealed for that to work. The chest tube is the only exit for air to leave the pleural cavity. and that air cannot enter in any other location. So her wound has to be sealed and eventually repaired, and there has to be a seal between the thoracic wall and the chest tube. And why didn't he put it, why do you avoid putting the chest tube inferior to the fifth intercostal space? Well, the diaphragm, when I exhale, the diaphragm goes back up to being in more of a dome shape. So when I inhale, it flattens out, exhale goes like this. Well, when I exhale and it domes up like this, it can actually come all the way up to almost the fifth rib. So I don't want to put a chest tube below the fifth rib for fear of puncturing the diaphragm. Chest tube requires careful placement. Let's see, hold on. I think I might have switched questions up on these. So why did they avoid placing the chest tube? Okay, so then we're going to jump to 3. Tension different from a typical. So you don't have to do 2C. Okay, a typical or simple pneumothorax, air enters the pleural cavity and negative intrapleural pressure is lost, causing the lung to partially or some cases completely collapse, and thus interfering with ventilation. The amount of air in the pleural cavity is relatively constant. So in that pleural cavity, there's not a heck of a lot of air there. There's a small amount of space, small amount of air, and quite a bit of fluid in there. So that's a simple pneumothorax. Air enters that pleural cavity, negative intrapleural pressure is lost. Remember, negative intrapleural. So the intrapleural pressure is roughly 4 degrees lower than pulmonary pressure. So the pressure inside the lungs is 4 millimmercury higher than the pressure around the lungs. Okay. Now, a tension pneumothorax, air continues to enter the pleural cavity with each breath, but cannot escape. That increase in pressure and volume can keep pushing and pushing and pushing the lung to shrink smaller and smaller. It can shift the mediastinum, disrupt ventilation, disrupt cardiovascular or heart rhythms. So typical or simple pneumothorax, usually not fatal. We can get you help with that. Tension pneumothorax is always fatal unless it's immediately treated. So you have to plug the holes. So if you come across a puncture anywhere in the thoracic cavity, you have to plug that hole. Otherwise, air is just going to keep flowing in and flowing in and flowing in until it takes up the entire thoracic cavity and pushes on the lung. Again, if it's only on the right side, you could still have that problem pushing against the left. Only on the left side, same thing. You're going to be pushing against the heart no matter what. Well, let's see. Brent, Dr. Harris, and chest tube. So that's why the chest tube, so the air doesn't keep going in. So we put the chest tube in, it levels out the air pressure. We can vacuum that excess air out. Okay, explain how significantly increased volume and pressure in the pleural cavity. Okay, so increased pressure and expansion of the pleural cavity lead to the compression of the superior and inferior vena cavae. So we're going to reduce then venous return to the right side of the heart, thus lowering cardiac output, lowering blood pressure. That can compress the atria, which also is going to impact cardiac function and cardiac output. Tension pneumothorax can be fatal if not treated quickly. What would you do if you didn't have a chest tube available? Well, air must be removed immediately to reduce pressure. So a large bore needle, of course, could be inserted. And again, you want to stay higher up, thinking through intercostal space on any of that. So first responders, they usually use a large bore, large gauge needle, not large gauge, small gauge, large bore needle into the second intercostal. That's going to allow the air to escape. You could also compress it by making a small incision in the thoracic wall, manipulating the wound edges so they remain open during exhalation. But anyhow, yeah, if you've got air just pouring in, then you can stop the air from going in, and then you have to be able to pull the air out. So that's what the EMTs are going to do. So anyway, that's that. I'm going to stop there. If you have questions, just let me know. Shoot me an email, or certainly use the Google machine. I'll see you next week. We'll go through number 10, which gets into nutrition a little bit. Have a good week.